afternoon, Sivile, to be with us and run us through the HIV package of care. So, Dr. Sivile, please pick it up.
Good afternoon, network. Again, Happy New Year. We hope that this is going to be a great year for us, the enthusiasts of advanced HIV disease care. And so just as a way of starting up the year, we are going to just have a high-level discussion on how we can scale up our advanced HIV disease care Zambia in this year. We share what we have in mind as a program, and also we'd like to hear from you. Next slide. So this is an outline. We'll look at the background, specifically on mortality, how we've performed, key issues on the implementation framework. This is a document that we released last year. We hope that it is in circulation and you have had a look at it. It shows what, where we are going and how we would like to do it. We also share a little bit on the stock status of AHD inputs. This is a question that we always get, and we'll look at the emerging issues, especially with regards to acutely ill patients. There's some development over there. Next slide. So again, the definition of AHD, these are things that we already know. Next slide. Next slide. And the burden we know already, we've discussed this. Next slide. And this is a package of care. We still want to offer CD4 cell count test for all inpatients, and there's a lot of emphasis right now this year for CD4 for inpatients and also viral load for those admitted. I would like to still emphasize on viral load tests for CD4 testing for those with high viral load. Those patients who are initiating treatment and those patients re-engaging into care. We still need to screen these patients. Would like to have a CD4-based diagnosis of advanced HIV disease rather than the clinical staging-based. Next slide. This is the algorithm, something that we are already familiar with. Next slide. Next slide, Tonda. The package of care, we want to emphasize X-rays for everybody who has advanced HIV disease. It's in the guidelines. The other things, they haven't changed. So we know where we are in terms of our performance as a country with regards to both prevalence at 11%, incidence at 0.3 in all populations, 3-4, and the 95 target, we are at 89, and that's our scale up of patients on ART. Next slide. So we did some analysis from the FIA. We can see that for those that are newly diagnosed, unaware of their HIV status, still the AHD prevalence is at 18% high, mortality still high. I know the Institute of Health Metrics and Evaluations, they've repeated their data. We'll have a look at it, but really, HIV still remains the largest cause of death in the country. Next slide. And these are estimates of deaths, 19,000 deaths for 2023. As such, our target is below 5,000, a very ambitious target. But still our services are averting just in 2023 over 50,000 deaths, people who could have died, and because of the great works that we are doing as a team. Next slide. Similarly, in terms of our percentages, we can see that of everybody who could have died from HIV, 70%, 3% are vetted, and only 27% results into actual death, something that we still have to work hard and reduce to less than 5%. Next slide. This is, I've pointed out to this, the estimated death still not reducing as we'd like them to. Next slide. And this is just as a proportion of how many people who are on treatment. You can see that we are doing fairly well there. It's slightly above 1%, 2%. Yeah, next slide. By age, this is an issue of concern. You can still see that we are having children, death still high, close to 3,000. Deaths with AHD, we haven't done much to talk about AHD and children. WHO has some material. We want to remind everybody that the big things is to look at nutrition. You have to look at vaccinations. Now, most of the killers for children are vaccinatable. There are vaccines for them, like pneumococcus. And of course, the TB has got the TPT as a prevention. So those are the big issues. We don't have much of crypto. But nutritional issues, diarrheas are big causes of death in children. And so we still want to encourage that. So that's not a good statistic. If you take it lower in age band, you find that it's still the productive age between 35 and 40. Next slide. And deaths are vetted by age. You can still see that we still don't want that 14%. Next slide. So we have the implementation framework, which we launched last year. This is what should take us between 2022 up to 2026. And we would like to just give you what is in there, those of you who've haven't taken time to have a look at it. So what we think are the problems with as useful here, good. What can we do for us to find people early? In testing is a good. Even our HIV testing, recent test, if most of the people we are finding and think that they have progressed. Right now, our recent test rate still hovering around 9–11%, not good enough. So we are not finding people early and to bring them into care. These are people who are healthy, who've just contracted, they're high risk. So really our testing services should penetrate areas of transmission. We are looking at the index testing, we are looking at sexual network testing. We're also looking at the key populations where the incidence of HIV is quite high. Those are the populations which will make a difference. Treatment interruption. So our data still shows that It's fallen to about 5% now, the latest data, but a lot of patients are still coming with AHD from that category. We have lab problems, pharmaceutical problems, human resource issues, M&D issues, and obviously our leadership, our organization. I'm going to speak a little bit more on those issues. Next slide. So this is the purpose of this document, and it really fits into the End HIV vision. Our guiding principles are listed there. Next slide. I wanted to speak to the objectives of the program, how our implementation. So really, we want to have some, to at least strengthen commodity security up to about 85% availability by 2026. We want to establish at least one hub and 2 spoke in each district. So it's at district level. So here you are looking at the very least, 116 hubs, and that would be close to 400 spokes. Is it 332 spokes at the very least? So this is where we would like to make sure that we start monitoring our progress. We want to have capacity to provide HD in all our 2,600 ART sites. There should be some form of ART services and indicators for HD should be able to eligible, screened, quality as well of HD service needs to be above 90%. Next slide. So really how our strategy is the hub and spoke model. This is what we want to use. Like I've said, each district should have the hub and spoke. So preferably it will be a district hospital. I'll refer to a district I'm familiar with, like Petauke, where I spent some time working there. So Petauke District Hospital can be a hub, providing services of a hub. Hub should be able to admit patients and take quality care of AHD. The spokes can be like urban clinic and the like. Then you can have a remote spoke, which a community health post or outreach post. But even there should be some form of HD services. You can see the ambulance there. The key is referral of patients to the hub and referral of samples. This is what we want to work out. Right now, our funders have been gracious. We know that FHI 360, they are supporting to do this in technical support in Eastern Province, Southern Province, the PHO is doing it as a COAG, Lusaka Province, the PHO I think is doing it with support from CIDAS, if I remember well, but ICAP is in Western Province, ZIA in Northwestern Copper Belt. So we and Right to Care, Northern and Chinga and Wapula. So we want them to operationalize this spoke and hub model this very year. Next slide with those targets that I've shared with you. So this is just a package that you expect that a hub test that should be there. We want hubs to have importantly CRAGs, CD4 testing, and indeed urine lab. Next slide. And the other services, you'll find all this. And this is what a spoke should be able to do. Next slide. You'll find these in the guidelines. We've had some challenges. CD4 cell count testing is still a challenge. We still have over 119 PIMA sites and a few sites that are using the fax caliber, the PIMA sites. Now we are out of PIMA reagents. Still looking at the pipeline. We've been looking at bringing the VCTech, the procurement challenges. We are using ZAMSA. We all know the challenges that we'll be having generally, and now the latest promise is that they will be available by the 30th of January this month. So M&D, crack tests, and just general case management abilities, patients are still slipping through the cracks. So these are some of the things we should work on. We've had some achievements. Our trainings have been superb via this ECHO platform and physical. We thank you for that. I think almost everyone participating in the program, implementation of the program, has been involved in doing these AHD trainings. There's been some improvement though in CD4 cell count testing. We've had some research and model projects. There are these model sites which have worked very well, UTH, Levi, Kanyama, and a few in the Cocoa Belt doing this work, great work. We have achievements. We need to roll out the hub and spoke model. Like I've said, partners have been given that role. We've written to the agencies to support that. And we did have an HDSI implementation from the Global Fund, which we'll be closing out, right? Soon, and this has been a success as well. A lot of work has happened to just help move forward. Next slide. I wanted to share the stock status before people ask so that I tell you where we are. So for CD4 cell count, for the FACS Presto, we are at 1.5 months of stock at MSL, at ZAMSA, sorry. Most of us have struggled to convert. So forgive us. Then, unfortunately, the PIMA, we are out of stock. So CRAG, it's available, 1.5 months of stock. Others are coming. LAMP test, we just have 65 kits, which are like 0.2 months of stock. But we must say that a lot of CRAG tests, 1,500 kits expired this December. And this, we need to ask ourselves, why? Are we ordering our lab colleagues? Are we speaking to them? They are responsible for this commodity. So we can't afford to have this much wastage of commodities. So these are the really things that we need to work on. VCTech, like I've said, 30th January, we are expecting the arrival. Next slide. So HD monitoring has been a challenge. Next slide. I just wanted to give you an update where we are. So please, we do have indicators for HD in the HI2. These are the indicators started ART with HD, currently on ART with HD. So we expect this to be filled and disaggregated by age. You can see the coding there, HD, HIV 3455, and the like. This, we are not doing it. Facilities, we were hoping, we are this transition where the HI2 should produce the reports, but we still have to make sure that this is being done correctly, because this depends not on the CD4, but someone should have made the diagnosis of HD. So we need this report, please. Next slide. So you can see the data that is there is very minimal. And we were this is by July last year, we thought that there should be more patients with HD than what we are seeing in the HMIS. Next slide. So we hope these numbers will start going up. Yeah, so this is breaking them by age. Similarly, we can do better. So it's just records are incomplete. Next slide. These are just the data quality issues that are there. Next slide. For the smart care process, so IHM, next slide. This is just where we are with from IHM's presentation side in terms of AHD and smart care. Next slide. The next slide. Next slide, sorry. Just to rush through. Next slide. Next slide. You can just skip these slides. Yeah, so in the both the the IHAP or for pediatrics and adults form, we do have areas for AHD. We hope that these will be filled as you are doing both the IHAP and the clinical follow-up form. So this is on Smart Care Plus, but similarly, even in the legacy, these data points are there. Next slide. Next slide, this is for the adults. So it's similarly, and this is how we are supposed to fill in. So HD care, does the patient, these needs to be filled so that we can have reports. We've had so many discussions over AHD and M&D. I think we have somewhere to start this year, and that place is to use the data platforms that are available so that we start having some data churning out. Next slide. And for the labs, similarly, you have where you can put the CD4 count and where they can do the clinical staging. Next slide. And this is where they are. You know, those who have advanced HIV disease, those particular elements, you can fill them in the legacy. Next slide. And these are the reports that we are supposed to get. Next slide. So it's built in. And if you're using paper-based, this is where you can put the elements, the data elements. So if you say the patient has advanced HIV disease, yes, you need to put it. But if it's a no, even a no has to be reported each time the patient does these forms, the IHAP and the clinical follow-up forms are being used. Next slide. So the other issue that I wanted to share with you is really the WHO did release how to provide care to people with advanced HIV disease who are seriously ill in the hospital. You can read through this document. Most of the things are things that we've discussed on this call, but it will enrich our approach and knowledge. But I want to share what we have in mind as a program. So the first thing is that we feel that the acutely ill patient, as you would imagine, the seriously ill should not be at peripheral sites and they have advanced HIV disease. Let's try and start moving them in these hubs. So our referral system should be developed or supported very much. And I'm going to share with you what we are trying to do in Lusaka to improve outcomes for these patients who are acutely ill. And pretty much we are looking at those who are severely immunosuppressed, a CD4 count 50, below 100, generally that they have TBs and so on. There's a lot of data that suggests that there's a lot that we can do to save those lives. This is besides those who need prophylaxis, screening, and the like. But if you find somebody who is acutely ill. So in Lusaka, next slide. We have a study called the DETURA, and this is just some protocol that I'm going to share with you. So we are trying to use this, like we've always done, to use studies, whether it's the HIV drug resistance and so on, because this is being also done by the program, is to use some of the resources and availability designs to reach out to our program, the designs of the study. So this study, the main issue is we are picking those who are seriously ill with TB and with severe immunosuppression, CD4 count below 100, and we are trying to see if we can give them adequate tuberculosis regimen. The regimens are higher. So next slide. Next slide. Next slide. Yeah, just fill up. So we know that TB it's a big killer, especially those who are severe immunosuppressed. Mortality rate, even here at UTH, the data that we have for TB is at 25% in hospital deaths. That's the data we have at UTH. You'd imagine in the peripheral sites where diagnosis is not done, treatment is not optimized, and so on. That's an assumption that at tertiary services, the care is better. If it's not better, our job is to try and make it better. Yeah, and this is across the world. And part of the thought is that the cause of the death, the first point there is that there's low plasma concentration of some of the TB drugs because you have enteropathy and you can't absorb well the TB drugs because you are very sick. Next slide. So what we want to do here is to have an intensive phase and which can reduce mortality, and this will have an increased dose. That's 3 times the dose, the normal dose for rifampicin, and twice the normal dose for isoniazid. And then we add systemic steroids for those who are very ill, and to see if we can save them compared to those who are, so it's a clinical trial, we would have to compare with those who are generally, those who receive normal regimens. Next slide, but the target is to reduce mortality at 48 weeks. Next slide. Obviously, it's a multinational trial which we are participating. Next slide. And those are the doses in the intensive phase. So rifampicin we are giving, we are not saying you do this in a trial. We are giving, instead of 10 milligrams per kg body weight, we are giving 35. Isoniazid is 5, we are giving 10 milligrams per kg body weight. Then you have the control arm, and we are giving the other drugs. We're looking for ways. The whole WHO is looking at what we are doing to see if this works. It can be a general guideline. So we need to really participate in this kind of work for our patients as a team, enthusiasts for advanced HIV disease. Next slide. Next slide. So the objective is really mortality, and we see adverse events and so on and so forth. and other drug-drug interactions and age-defining illness. But the main issue, those are secondary objectives. The main issue is mortality at 48 weeks. Next slide. To reduce death. So for sure, if you are doing something with an intent of reducing death, then it has to be a must-do in medicine. This is just some of the secondary objectives. I'll skip them for the sake of time. Started late. I'll skip this as well. Yeah, so really we are looking at adults with a very low CD4 count, with HIV, and who are hospitalized, meaning that they are very sick with a CD4 count very low, and they have TB defined by expert, lung, or chest X-ray, and these we need to randomize them and give them those regimens. Next slide. So those who have initiated TB for a long period of time, more than 7 days, obviously they can't be randomized, so they are not eligible. Those with history of TB probably have resistance, not what we're looking for. Those who need steroids, or those who have none, who have resistance, or they have MAC and that sort of things, they are not eligible. Or those who have problems with the drugs, hypersensitivity, liver failure, and things like that, liver toxicity and things like that, they are not eligible. Next slide. Yeah, we can skip this. I think speaks to the same, and we can skip this, the synopsis. Yeah, so we are doing this in Lusaka, in those sites. So what we are asking is, if you find patients who fit that criteria, call us, and we do have people in this site so that we can move them to UTH. And because that's the hub, Lusaka, these other sites are spokes for our AHD hub and spoke model in Lusaka. So Ulevi is another hub that we've identified. We have University of Maryland who's been working and supporting it, and we want to activate it. We should have done that this month, but really the cholera, it's been a site for cholera. We thought there's just a lot of confusion because it's the same team that is still responding to the cholera. So, and it's a site where we're admitting cholera patients, so we decided to use it. We hope to expand to other spokes in Lusaka. But these are similar things. This is the model, hub and spoke model, that we hope that all other centers or districts should start implementing. So this is just a summary of priorities that we wanted to share for this year. The main issue is, let's have the hub and spoke model operationalized. You hear us talk about this again and again. At the very least, one hub in each district and 2 spokes. That's what we are asking for. And you know how a hub should look like and how a spoke should look like. This is what we want. We'll roll out the VCTech. We'll continue to have mortality audits who visit. You remember we shared some 6 sites. We have some support from the CDC to continue doing this work. We'll visit those sites to discuss what we found. We do have CQA tools, service quality assurance tools that we've also used in some of the sites for AHD, and would like to continue using those tools that work. So we would ask a number of you to continue administering periodically those tools so that we are getting this data of how is the AHD service performing, because we need to measure that. and the quality thereof. But most importantly, what we found in about, I think, 6 or 8 sites that we did this, we found that there is non-existence of community AHD services. So we need to think about how we can do that. How do we improve AHD services at community level? So this is one of the gaps that we've noted. So just a thought for all of us as we are planning for the year. We know that the number of IPs are supposed to be helping us doing the HD work. M&D is still a big issue. We need to continue improving the M&D. I think I had explained at length those tools that we have. Let's put the data, those data elements. Thank you very much. Thank you, Dr. Kozia, for inviting me to set the ball rolling for the year, as we want to push this work further so that our goal is to reduce mortality that is resulting from HIV in Zambia as a AHD team.
Thank you very much, Dr. Sivile. We appreciate the direction you've given in the Advanced HIV Disease Program and the emphasis on the hub and spoke, including the emphasis on community as well, getting involved in AHD as well. So we want to give the opportunity now to all those that have joined in to just raise your hand. If you have got any clarifying questions, then you can just ask. And then I see that the comment box, we don't have any in the chat. Okay, there's a hand by Mungomba. Please go ahead, unmute.
Yeah, thank you very much, Dr. Kozia, Dr. Sivile, for this wonderful presentation. Quite interesting, and I'm very sure with the guidance given, we are going to make a great improvement in the advanced HIV management. Just areas of clarity in regard of registers where advanced HIV documentation is concerned. When we look at the two which we've administered of late, you'd realize that there are certain facilities having the commodities, but are not able to even document what is being done. Some facilities are using improvised register just to capture some of the few things. So I'm not really sure what is the guidance in regard of the recently adopted registers by Lusaka province, if that is the view for MOH to have them used even in other provinces. Then secondly, Dr. Sivile, Visitech, I believe, is the new CD4, some kind of reagent, the rapid test, if I've not mistaken. And if that is coming on board, it is really going to help. Now, may you highlight more on the rollout plan so that we see how best we can really go in and have this advanced HIV package implemented with fidelity. Thank you.
I can see we have an intent, someone following this deliberation intently. Dr. Sivile, your responses.
Thank you, Dr. Mungomba. And I saw Chingola there. I was worried, have you left us in Lusaka? You're in Chingola.
Sivile, I'm the lead mentor now for Copper Belt. Thank you.
You didn't say goodbye.
Apologies.
We lost everyone. All the mentors.
No. The nation has benefited.
The nations that has been Lusaka, I'm sure. I'm saying Lusaka we've lost everybody. Oh, congratulations. Yeah.
Thank you.
So thanks for those questions and very important questions. Probably I should have included these facts in the presentation. Registers. Yeah, so the indicators for advanced HIV disease cannot be done properly using paper-based registers. So we hope that Smart Care, which can give us all the data, can give us that report, and that's what we are working on, and IHM is working that. But in the meantime, that's why we haven't produced an AHD register, because the direction, we think the solution is to have the AHD reports be in Smart Care. Yeah, and you can see that most of the AHD work will be done in hubs and those spokes. Those are relatively big facilities. Our target is we think those facilities actually have Smart Care. We'll be surprised if they don't, so they should be able to do the work. So we've avoided to go both sides. Paper here, you are still improving on Smart Care. But in the meantime, facilities are giving us this data, and they are using all sorts of work, all sorts of modifications. We are saying continue to using those modifications. Others have come up with separate standing NCD and HD register. It's fine, because as an implementer, you can use that. We are okay for now, but we've told you what the solution is. Others, what we had recommended was in all registers. For instance, HIV testing registers, you have to put the AHD column. You can change that, to show that the TX knew those, what's their AHD. The linkage register, I'm not even sure if it's still there. You can put a column of that. The DAP, or the daily activity register, you can put a column, those who've come, who has HIV and so on, who has AHD and so on. You make those modifications. We feel that was going to be easier for everyone. But at the end, what we want are those reports which can be put into the HIA tool, and also which can be put in Smart Care. If you have Smart Care, it's very easy, very, very easy, is to make sure that those data columns, as patients are being seen, those are being put. So that's our vision generally for the M&D section. What we want is to fill in those data points using the improvision that you are doing. For sure, we are seeing data. For instance, Southern Province, they give us reports from hospital, AHD, they give us reports from those who are being tested for the new TX new patients for AHD. Or Visitech rollout, another excellent question. So we still have fax count, fax presto in, and PIMAs in for facility-based. We are receiving about 80,000 units for Visitech. Some partners are buying on their own. I know Western Province, they should be coming, procured by ICAP. But what the general guide is that Visitech should be used for HD in the lower facilities, in the spokes and the mini spokes. Especially, we'll probably distribute them. We have a list where they'll go in the high testing facilities, those facilities that are getting high TX new. Because we want to use, after somebody's tested, at the linkage point, We want to know, is this AHD and not AHD unreported? Remember AHD in the new, our indicators, it's AHD in the new patients and AHD in the old patients. Those are okay. So we want to use it for the AHD in the old, on the new patients chiefly, because it's much easier, faster, and so on. For inpatients, facilities that are admitting, you can have a machine there. Kanyama has a machine, UTH has a machine, Suilanji has a machine. They should be able to do that for those who operate as either as hubs or semi-hubs, as it were. So that's the vision, and unfortunately, the list is there. If the team feels this can be done differently, it will be done differently. The lab team still insists that the technology should be lab-based and not be done by CBVs. We'll have facilities where we'll have to try if CBVs can give us correct results as an implementation science project. I hope I've answered your question. Thank you.
Thank you so much. Kazadi, we only have a few more minutes before we wrap up. Maybe we give a chance to Kazadi Kashikula.
Okay, thank you. Thank you so much, Dr. Sivile, and thank you, Dr. Ziambo, for the opportunity. Thank you so much for this presentation. I believe as facility, this was documentation and reporting of advanced HIV disease is concerned. I have nevertheless not really a programmatic question, but a practical clinical question where I need Dr. Sivile help. In clinical practice, we are initiating patients into rapid initiation and same-day initiation policies. Patient, of course, who clinically are stage 1 and stage 2. And then later on, when they come for their review, we find that the CD4 count that was collected as baseline comes out less than 200. And we further continue with the guidelines and collect TB-LAM and cryptococcal antigen test on the serum. Should this investigation come out positive, how do we really manage this patient who are really just initiated a couple of days or weeks ago? So that is my concern. I would like Dr. Sivile maybe to give us a practical hint on how we actually approach this type of patient. Thank you.
So the hint is don't stop the ART. That's the guide. Yeah, so if you started the ART and you find somebody has TB, even if it's TB meningitis or it's indeed cryptococcal meningitis, you still don't stop the ART. I think it's as clean as that. If people want that to be in the guidelines, we can put it in the guideline, but I think we can't put all the special cases in the guidelines. There's no controversy about that guide. The guide is simple. You don't stop the ART. You just monitor the patient a little bit closer for iris. For TBM, those are patients who should have steroids. For those who are who have cryptococcal meningitis, those are patients that you want to do repeated CSF, repeated lumbar punctures while they're the 2 weeks while they're on treatment.
Thank you very much. A very good practical question. And I can assure you, we have actually scheduled a number of topics to address some of those issues in the coming weeks on advanced HIV disease echo. That being said, we've come to the end. Unless you have got some final points you want to highlight.
Yeah, just to wish the team a fantastic year, 2024. And we hope that together we'll reach all our targets that we set for ourselves for a year. And stay safe, those of you who are in hotspots for cholera. Assist us in the response, but also stay safe. We have a number of HIV, AHD patients in the cholera units, and those are the ones that are dying. It shows that the problem is still there. Thank you.
Thank you so much, everybody. We will be with you yet again next week. Do have a pleasant day. Bye for now.